Crisis Prevention and Intervention in Healthcare. 1.0 Introduction. A clear pattern of how violence occurs has been identified. There are preceding observations that can be made before a person progresses to become assaultive. Lindsley, 2000, p. 48. This chapter will describe the cycle of assaultive behavior, provide predictive factors for aggression and violence, and educate on the appropriate interventions. 2.0 The Assault Cycle. The assault cycle has distinct patterns that can assist in predicting violence and enable the healthcare professional to administer appropriate measures. The patterns in assaultive behavior are common in different groups, genders and persons. In every cycle, different behaviors can be observed in particular phases. The 5 phases of the assault cycle include: 1. Trigger, 2. Escalation, 3. Crisis, 4. Recovery, 5. Post-crisis. 2.1. Trigger phase. An individual begins to detect threats to their security or welfare. Feelings of being denied, being ignored, or being refused something important to them crop in. The aggressor then becomes frustrated, as Lindsley, 2006, p. 48, highlights. A person in trigger phase perceives that they have lost control. They review the issues facing them and see the magnitude of the conflict as huge. Fear is real, and the person in crisis tries to compensate for what they are denied. They may be in denial and reason with self to justify events. The trigger is as a result of other people's actions, an argument with another person, upsetting information, and inability to do something they have been denied, such as consuming alcohol or even a smoke break. Crisis can be eliminated if the problems and conflicts are solved. Trigger phase is not associated with experiences of medication or hallucinations. The appropriate response towards the potentially aggressive person would be to divert their mind and engage them in a meaningful discussion. Exercising good communication skills where one remains neutral would be helpful. The therapeutic communication skills used in this intervention is called verbal de-escalation. Discuss the issue making the patient uncomfortable and try to proffer solution. A healthcare professional can alert others and record observations. The healthcare professional should remain calm and avoid showing signs of fear. Keep a distance, show the hands, and stay close to exit. 2.2. Escalation phase. The assaultive person begins to prepare for aggression. Threats are presented verbally to the prospective victim if they are within reach. Anger steps in and the aggressor throws objects, begins pacing and kicking walls. The voice is raised and yelling that is sometimes accompanied by banging is experienced or seen. The escalating phase provides an opportunity for a healthcare professional trained in crisis intervention to employ de-escalating techniques to prevent violence from occurring. If possible, explaining to the aggressive person that consequences of violence can be severe can be helpful. This can be done with caution because it can be perceived as a threat to the aggressor. Adamowski et al., 2009, p. 740, adds that, the thinking process is affected by the high levels of anger and distress. Consequently, the aggressor begins to become dysfunctional, disorganized, and lacks sleep. They may direct their anger to animals or objects rather than directing them towards a person. Very minor events become a cause of argument. 2.3. Crisis phase. Crisis stage involves actual aggressive behavior. The aggressor assaults the seeming threat. A lot of energy is used in violence. The assaultive individual becomes weary very quick because the energy to sustain an attack is limited. In the crisis phase, the aggressor dominates the victim by controlling with violence. The abuser is unpredictable and fears losing power, therefore, they use violence to control. The aggressor believes it is the victim on the wrong. The victim of assaultive behavior is abused, feels helpless, and becomes traumatized. To ensure they have control, the abuser takes time to decide words to use and place they will use for abuse. They scheme and attempt to do what they have planned on the victim. 2.4. Recovery phase. After becoming assaultive, the aggressor slows down to recover. The aggressor is watchful and any impending threats could generate another assault. The feeling of being disorganized remains and the aggressor becomes confused. In the attempt to recover what has been damaged, the aggressor reconciles by showing affection and apologizing. The abuser ends violence and demonstrates their desire to change. Because of feeling remorseful, the aggressor becomes sad and shows that they are repentant. In some cases, the aggressor refuses to apologize and ignores the violent event. They leave the victim without saying a word and disappear. Some return and request the victim to sympathize with them. They become very convincing to justify their act and profess that they will not repeat assault. 2.5. Post-crisis phase. The aggressive individual calms down and becomes emotional about their actions. They show intense remorse, fatigue, and despair. They begin to blame self and hide from others. The aggressor might begin crying, sleeping, or just remain alone in a corner. In some cases, the aggressor does not show remorse and may be happy about the violence. What causes the cycle to begin is when interpersonal difficulties arise. When the interpersonal issues continue to add, the situation becomes different and tension begins to build, causing the cycle to start. Positive talk and affirmation should be emphasized to decrease the chances of triggering another cycle of violence. The aggressor can engage in different activities like recreation and exercising to divert their mind. Mark the triggers of assault and avoid mentioning or accommodating them. 3.0 Aggression and violent predictive factors. As assaultive behavior continues to become a major concern in healthcare, factors that precede violence have been discovered. The knowledge of these factors ensure the safety of the healthcare professionals as well as the patients and their families. 3.1 Demography and personal history. In the healthcare facilities, demography and personal history play a major role in providing information on the possibility of aggressive behavior. Chapman et al., 2009, p. 476, mentioned that an individual who have shown threats of hostility and belong to a group or subculture that engages in violence could be a prospective violent person. Male patients are believed to have higher likelihood of becoming violent than women. Healthcare professionals take into consideration the history of the patient, healthcare worker or visitor. Aggressive tendencies in the past can be identified as a possibility for aggression in the future. Incidents of cruelty towards self and others are used to determine the possibility of aggression. The presence of men as the majority in aggressive behavior may not be necessarily correct in relation to violent behavior in healthcare. Young people tend to be involved in violence than older people. There is a correlation of low-income earners, unemployed, low literacy levels being a contributive factor to violence. Healthcare facilities report high cases of violence occur at night as opposed to the day. Aggressive people become violent towards the victim if the victim is alone and is female. When there is less surveillance from the hospital guards and visiting time for patients, violence tends to occur. When the aggressor sees that there is no security, they are likely to take the opportunity to exhibit violence. The frequency of assaultive behavior in a given population is used as a baseline to predict violence. Use of rates of previous occurrence to predict possibilities is considered to be an actual factor. 3.2 Individual disorders, sickness and substance abuse factors. The individual may be having personal crisis where they lost control or power. Anxiety disorder is regarded as a ground for causing aggression and can predict violence. The aggressor may be on drugs. Delirium can cause violence if the patient has seizures, infection, and trauma or electrolyte imbalance, reversible. Brain injury, dementia, excess alcohol and Alzheimer's disease can contribute to the development of aggressive behavior. Previous mental problems like paranoia, personality disorders, psychiatric illnesses or psychosis can predict violence. Morrison et al., 1998, p. 558, argue that attacks towards healthcare professionals are not abrupt. Patients and healthcare professionals who become assaultive can be identified before they become violent. Prior to becoming violent, the aggressor will experience increasing tension, issue threats and become stressed. History of violence is one of the reliable factors for predicting violence. Employment, literacy level, ethnicity and gender are weak factors for predicting violence. Loss of trust for the physician, visitors, relatives and other healthcare professionals in the hospital can lead to wild suspicions that will inspire aggressive behavior. Provocation to cause violence is a situation that may eventually end up causing violence. Beleacki et al., 2010, p. 27. Individuals who are unable to tolerate stress can become assaultive. People with psychiatric disorders such as schizophrenia, depression and bipolar together with schizoaffective disorder are prone to becoming aggressive. Substance abuse and excessive consumption of alcohol is a prominent contributor of violence in healthcare facilities. Patients with mental disorders and the psychotic consuming alcohol have a higher tendency of becoming aggressive than those who do not consume alcohol or abuse substances. 3.3. Situational factors. Ferns, 2006, p. 42, states that situations that facilitate occurrence of violence can be used as a predictive factor. The availability of weapons such as knives, guns, sharp objects where the aggressor can access them could lead to aggressive behavior. The presence of a person who stimulates the feeling of injustice, oppression as well as inequality can trigger abuse. When the person is forced to feel threatened and defenseless, they become aggressive. Individuals who have experienced abuse from self or others in the past can quickly become aggressive if same condition is applied to the present. If the person feels isolated from the rest of the people and is removed from their place of comfort without consent, they may not welcome the change and instead become aggressive. When something unexpected occurs, the event can stimulate anger which can eventually erupt into violence. There are prevailing circumstances that encourage violence such as overcrowding, favors towards others and uninformed rules. Healthcare facilities have been used as a holding place for detainees and people serving a jail term when the correctional institutions are crowded. Sick prisoners are also taken to the hospital for treatment. When in the hospital, the detainees can become aggressive to self, other patients, healthcare providers and other people within reach. The emergency room is usually a venue for assaultive behavior for the following reasons. Long waits could trigger violence. Mental health patients' first contact before treatment. Patients with other diagnosis first contact. 3.4. Actuarial and clinical predictive factors. Violence has been given different approaches to include clinical, actuarial and structured methods. Predicting violence has been seen as a very challenging task because assaultive behavior has occurred even in circumstances where no risk had been detected. Actuarial methods of predicting violence take into considerations risk factors such as diagnosis, psychopathological condition, gender and age, statistical assessment. Actuarial methods predicted violence if the same patient is exposed to same conditions in the future. As a result, the method does not recognize the judgment of the healthcare professional dealing with the current situation and is often used for admitted patients. Data collected on the specific patient is used to make the judgment if the person is likely to become aggressive. Clinical methods of predicting violence have been used to predict overt behavior and consider factors such as psychopathology. Clinical methods are structured and assessment is done according to situation. 3.5. Broset Violence Registers. According to Abderhalden et al., 2006, p. 17, prediction of assaultive behavior is possible during routine care. Healthcare professionals can forecast violence using the violence register on a short-term basis. Violence checklist consists of 6 observations of the possible aggressive person. The observations include irritation, confusion, abusive and threatening words, and boisterousness, attacking animals and objects and physical threats. When the 6 observations are recorded, there is a higher probability of the person to become violent. 4.0 Conclusion. The assault cycle begins with a trigger when the behavior of a person changes and tension begins to build up. The next cycle is escalation phase where the body and verbal words reveal unmanageable anger. The next phase is crisis where the aggressive person acts violently. After the crisis, the aggressor enters recovery phase when they begin calming down. The final phase is post-crisis phase where the assaultive person becomes remorseful. In an attempt to resolve issues, the aggressor and victim can disagree, leading to a trigger, hence the cycle begins again. This must be avoided. Ways of de-escalating violence should be exercised to prevent assaultive behavior. Aggression and violent predictive factors include demographic, age, gender, history, disorders, sickness and use of substance, situational, prevailing circumstances, actuarial, clinical, and Broset Violence Register predictive factors.